Hello, everybody, and thank you very much, Anusha, for the introduction. So I hope everybody can see my screen, and I will start with a little bit of a primer about tinnitus and the brain. And as you already heard during one of the previous TRI Academy sessions, the most common cause for tinnitus are cochlear damages after noise trauma or hearing loss in general. And in fact, as Stephen already said, around 80 to 90% of tinnitus cases have a certain degree of hearing loss. And in the generation and maintenance of tinnitus, peripheral as well as central mechanisms are involved. And the prevailing assumption about the generation of tinnitus says that due to a reduced or missing acoustic input from the periphery and the lack of neural input to the auditory pathways, a maladaptive neuroplastic changes in the central nervous system are formed, and those are said to be responsible for the perception of a phantom sound termed tinnitus. And pathological changes associated with tinnitus are, for example, abnormal neural synchronicity along the auditory pathways and reorganization of the tonotopic map of the auditory cortex, as well as hyperactivity in auditory brain areas, and also in non-auditory brain areas, pathological alterations can occur. And those pathological neural circumstances are said to be a significant leverage point for the application of recent neuromodulation techniques. And with today's talk, we want to give you a little bit of an insight about the methods we are working on. So my colleague Laure will talk about transcranial electrical stimulation with a special focus on direct current stimulations, and I will talk about magnetic stimulation with a special focus on a repetitive transcranial magnetic stimulation. And if you're interested, for example, in other non-invasive brain stimulation methods like vagal nerve stimulation or multimodal stimulations, I can only highly recommend to you to read the work from Bertolt Langhout or Dirk de Ridder, and you can see them at the bottom of the slide. So I will directly start with TMS, transcranial magnetic stimulation. So TMS is considered a safe and well-tolerable non-invasive brain stimulation method. It's based on the principle of electromagnetic induction. So a current flows through a specific coil, generates a magnetic field. This magnetic field can pass through the cranial bone, generates an electrical current at the surface, which is able to depolarize the underlying cortical neurons. So in easily said, we're able to induce action potentials. And if, for example, we apply a single TMS pulse over the left motor cortex, we are able to generate directly peripheral muscle responses termed motor-evoked potential. So you can see, of course, you need to stimulate with single pulses at the right position. You can see muscle twitches, finger movements, and hand movements. And if we apply such single TMS pulses in a rhythmical manner at a specific frequency, this is then termed a repetitive transcranial magnetic stimulation. And from such basic research, we know that low frequency RTMS acts inhibitory, so it decreases cortical excitability, and that high frequency stimulations act excitatory, so they increase the cortical excitability. And what we also know is that if we apply single RTMS sessions, this can produce effects which last up to 2 hours. And if we apply it in daily sessions, so over several days or weeks, the effects are long lasting and therapeutic effects take place. And that's what we are aiming for in tinnitus. And already 19 years ago, low frequency RTMS was introduced in order to reduce the hyper or overactivation of the left temporal cortex. And those early studies were very promising, which also led to the fact that 1 Hz RTMS applied over this cortical region acts as the commonly used RTMS protocol for the treatment of tinnitus. Typical treatment scheme are 10 sessions over two weeks on 5 working days with 2,000 pulses per session. And in this regard, since that time, over 60 studies were conducted, and the findings of those studies are very heterogeneous, and they're also characterized by high inter-individual reliability in treatment responses, which means that only a subset of tinnitus patients responds to treatment with RTMS. And this is also, or this uncertainty is also exemplified by 2 large-scale placebo-controlled randomized clinical trials. They also showed different results, even when using almost the same methodological approach. So both used 1 Hz RTMS, and the study on the left side from Folmer et al., they were able to show a superiority of an active RTMS compared to placebo TMS group, as well as the number of treatment responders was higher in the active RTMS group. And on the right side, you can see the study from Landgraf et al. They did not find any superiority of a real RTMS compared to a sham or a placebo RTMS stimulation group. And based on this uncertainty, as well as the fact that pathological changes in tinnitus do not only occur in auditory areas, but rather a network of non-auditory and auditory parts of the brain, other studies went one step further and also investigated prefrontal RTMS, as well as high-frequency stimulation protocols, which are normally used as a treatment for depression, for example, in order to counteract the hypoactivity or the underactivation of the left dorsolateral prefrontal cortex. And we all know that depression is a common comorbidity in tinnitus. Other studies investigated a combination of prefrontal and temporal stimulations, for example, triple site stimulation, the study from Lehner et al., or even combinations with psychotropic medication, peripheral muscle stimulations, relaxation techniques, as well as low-level laser therapies, for example. And this picture, or this uncertainty about the effectiveness, is also exemplified by several reviews conducted and meta-analyses showing also very different findings. For example, some state very limited support, some say there's evidence, others conclude RTMS is not recommendable or there's a potential efficacy. And the recent guidelines for the therapeutic use of RTMS states there's a level C recommendation, which means that there's a potential efficacy of its application in tinnitus. And this is in contrast to the common guidelines or the current guidelines for diagnosis, assessment, and treatment for tinnitus. So the European guidelines, they state that it is not recommended to use RTMS as a treatment option in tinnitus. And there's also more recent meta-analysis, which also states a potential effectiveness, especially if RTMS is applied over the auditory cortex, like the very early studies or the classical studies did. So taken together, we have heterogeneous findings of different studies using various approaches, very different protocols. We have also heterogeneous findings of large-scale placebo-controlled RCTs, as well as different conclusions from several meta-analyses and reviews. And to sum it up, so at the current stage of investigation, the clinical effectiveness of RTMS for tinnitus is not obvious, and potential reasons why could be, as I said before, we have high inter-individual treatment responses and only a subset of patients respond. And maybe this leads to the fact that those single subject responses do not translate into overall effects, so we do not see it on the whole group. Also, RTMS research in general has many technical degrees of freedom. For example, in the case of tinnitus, we're not quite sure which stimulation frequency is the right one, how many pulses do we need, how many sessions we need, which one is the right stimulation position, and also subject-related factors need to be considered. For example, it was suggested that the brain state before stimulation is relevant for the intended effects of RTMS, and that under specific circumstances, this effect can also switch, which means there's a complex interplay of brain-related and also technical-related factors in RTMS research. And what does this mean for the tinnitus brain? So it could be the case that those pathological hyperactivity we have in tinnitus acts as an intrinsic state of the tinnitus brain. And it could be the case that the supposed effects, for example, which we want to intend, or we intend with low frequency stimulation protocols, might switch from inhibitory to excitatory, because those effects were investigated on the basis of the healthy brain. On the next slide, I want to give some suggestions on how to continue. For example, we can identify, or we need to identify, potential neurophysiological markers, which can then be targeted during treatment, but currently it's not clear, or there's not a clear correlation between neural and behavioral data in tinnitus. Or maybe we can also identify predictors of RTMS responses. For example, a recent study from Pöppel et al. Showed that treatment responders in RTMS showed a specific anatomical brain pattern with respect to structural MRIs. Or we could investigate RTMS periodization, as we do, for example, here in Regensburg, on the basis of short-term tinnitus loudness suppressions and by so-called test sessions prior in treatment, where we test different short RTMS protocols if they're able to reduce the tinnitus loudness temporarily or briefly This information then is used for the normal daily treatment. And there are also 2 studies conducted in this regard, and both of them, as you can see here, are not able to show any superiority of personalized RTMS compared to a standard RTMS treatment. And yeah, so there's further investigations in this regard are highly needed. And I want to close my talk with some final remarks. So not much is understood in RTMS and tinnitus. I think we're more or less at a very early stage of investigation, and we need, of course, further trials with more sophisticated experimental designs, as well as well thought methodological approaches. And hereby I want to thank you for your attention.